So good afternoon, everyone. We're going to get started so we can end on time, and everyone is welcome to enjoy a luncheon. So this is the first in-person Dean Seminar series that we've had in a few years, as you know. And it is my great pleasure to introduce Dr. Georges Benjamin, who's going to be our Dean Seminar series today. And our sort of inaugural come back to in-person seminars and discussions. So thank you for your willingness to come on board. So this is a very special day. We all know it's Public Health Week. We all know the important work of public health. We are all working very hard to make it visible and better and better. And how lucky are we to have APHA here, the originators of National Public Health Week, in our room, when I'm pretty sure you could be just about anywhere today celebrating public health. So thank you very much for coming, Dr. Benjamin. So I wanted to give you a few comments about Dr. Benjamin, so you know who's in front of you today. And I think of him as the non-federal leader and face of public health. We certainly think about CDC and maybe to a lesser extent NIH as public health leaders, but APHA is the association that is dedicated to making everyone healthy and keeping them healthy to the extent possible. I am particularly fond of the organization because as a graduate student, it was the meeting where I gave my very first talk on spontaneous abortions. I remember that. I remember the questions at the mic at the time. So those kinds of events in your career have a lasting impact on your thinking. And so it is a great honor to have Dr. Benjamin here today. He is the executive director of the American Public Health Association, APHA, a position he has held for some time, since 2002. You can't read about public health without seeing his name. And previously, Dr. Benjamin was the Maryland Secretary of Health, where he was responsible for notable accomplishments in improving the health of Maryland residents and the quality of the state's Medicaid program. And as a college that is devoted to serving under-resourced and medically underserved populations, we know how important that is. That budget was a little bigger than the universities, at $4.5 billion. I took note of that because I always think about what it takes to lead an organization of that size and over 10,000 state employees. By matter of background, Dr. Benjamin is a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine. He is board certified in internal medicine and a master of the American College of Physicians. When I first read it, I thought it was a typo. So I went to the American College of Physicians and I looked up to see if I could find masters. They don't say very much, so it must be a very distinguished honor. And so I'm very pleased. I don't know how Dr. Benjamin has found time to publish with a number of papers that he has published, about 160 articles and book chapters, in addition to a recent textbook, The Quest for Health Reform, A Satirical History, which is an expose of nearly 100 years, a quest to ensure quality, affordable health coverage through political cartoons. So if you haven't had a chance to read it or look at it or enjoy or chuckle with it, take a look. Of Dr. Benjamin's many accolades, awards, and special recognitions is his election as a member to the National Academy of Medicine of the National Academies of Science, Engineering, and Medicine. He also has served as a board member for various organizations, including Research America, the Reagan Udall Foundation, Environmental Defense Fund, and the Truth Initiative. I could go on and on about his awards and special recognitions, but in looking through that list, there are qualifiers that seem to repeat frequently, and those are words such as executive, influential, expert in the title of those awards. So we're delighted to have you here celebrating at Mason as we celebrate the university's 50th anniversary and are moving even closer to becoming Virginia's hopefully first college of public health in the near future. So thank you, Dr. Benjamin.
Thank you.
And you don't have to stay behind there if you're
Oh, that's right, I don't. Okay. Well, good afternoon, everybody. Thank you very much for allowing me to spend some time with you today. And I understand this is the 50th anniversary of the school, so that's pretty exciting. That starts off, I guess, today. And some of you may know this is the 150th anniversary of the American Public Health Association. So we're celebrating that this year as well. What I want to do today is just kind of talk a bit about public health. What we need, I think we need to do to kind of build this system as we go forward. And let me just start with the fact that the practice environment for public health has just dramatically changed. Obviously infectious diseases, which is kind of what we were built on, is certainly a big deal. But chronic diseases are still there, still prevalent. All the epidemics that we had going on before COVID are still there, whether it's guns, as a manifestation of violence, whether it's HIV/AIDS. We had a rising epidemic of STDs. So all the stuff that we were dealing with is absolutely, frankly, still there. And, as we think more and more about this operating environment, we're in a much more globalized world. There's no question that this was certainly a pandemic that was globalized, but we had globalization of our food. We obviously have globalization of transportation and all the risks from moving people from point A to point B in a globalized world. And now, of course, globalization of information. And this just continues. We've had some very disruptive technologies. I've been very much on top of tobacco for many years. When I was in the District of Columbia, we were very active dealing with tobacco. And, we've been celebrating the fact that we have really done a really great job of reducing people's utilization of tobacco initiation, getting people to quit, pretty high quit rates. And then we got e-cigarettes. So disruptive technologies abound. And then, of course, public health has now become overtly very, very, very political. And I would argue that there's even a war on science. Now, if you actually do look at the surveys say people trust science, people trust scientists. While we still see people are generally saying they're distrustful of the healthcare system, but they like their doctor. It's kind of the same thing to a politician. They don't like politicians, but they kind of like their politician. So just understand that while there is this issue of war on science, we usually need to use a science-based approach to addressing it and not let it scare us. I point out often that public health in the United States, unlike other nations, is a federal, state, local partnership in the governmental side, strongly enforced on a foundation of a range of nonprofit entities that engage in public health. That's important because our country is built on citizen science. Trying to put the public back into public health is very important. And none of this happens if the public's not in part of the process. And that happens through organized collective action of individuals, primarily through a range of non-governmental entities working in partnership with our federal, state, local partners. It's not really well harmonized in many ways. We kind of know what our roles are, but in many ways, we often trip over one another. The fact that this system developed over time, I would love to say that we sat down with a white sheet of paper and we designed public health to be a really great, wonderful thing. If you think about how CDC developed over time, it is an entity that is some member of Congress got a great idea, some member of the administration got a great idea, they got something funded and they created a center. They didn't ever put enough money in there to make the center really functional. No one said, what are the leading causes of death? And we ought to really investigate that and focus our funding on those areas. And they didn't. And so we have what we have. We have this patchwork system of public health, which is grossly underfunded compared to what we have in the healthcare system. Recognizing that in the rest of the world, the umbrella for public health is public health, with this little thing over here called medical care and healthcare. In US, we have the medical care system and we have the public health system. And so we have this really very different system from the rest of the world. Now, we'll see what happens as we go in the future, but just understand that the system was never designed by anybody that was having a rational thought about how we would try to really improve the public's health. We do not have every governmental public health agency, for example, has a comprehensive chronic disease program. They certainly don't have comprehensive injury programs. The amount of money that we put in these programs, we normally put a little bit out and the CDC tries to grow them over time. And then of course, people are always pulling money away. Even our immunization program, which is primarily funded through federal dollars. Every now and then a governor or a governor's spouse would decide, because his kids and his mothers and immunizations historically were nonpartisan and non-political, that's obviously changed, would decide to have an immunization campaign, and they would throw a little bit of money to support the federal money that came in, and we would always have an immunization effort because of that. We never had an adult immunization program, although there actually is for the first time funding in the proposed budget of the president for the first time an adult immunization program, which I think is very exciting. Just understand again, we have not, this system was built over time and wasn't really built in a comprehensive way. It's governed, and I don't know how to make this statement much stronger other than to say the governmental public health entity is the only entity that has a legal responsibility for the health and well-being in the community. Let me say it again. The governmental public health entity is the only entity that has the legal responsibility for the health of the community. It's not the local hospital, despite the fact they have a community benefit responsibility. It's not the city's transportation program. It's not the environmental health program. It is generally your state's or municipalities' public health entity, which by law and statute has that responsibility. In fact, many of the powers of those health officers are separate from the governor's powers. The governor doesn't have the power, for example, in most places to quarantine. That's a health power, although they sometimes seem to think that they have that power. And I just say that because our public authorities are now very much under threat. People become reactionary. They haven't quite thought about what they're doing. They've decided to go after the people that are forcing us to wear masks and get vaccines and stay in our homes. I have this wonderful set of slides. I didn't put them in this talk for the interest of time, but back in the last, back when we had smallpox, and there was a big smallpox outbreak in Milwaukee, and the health department managed it very poorly. They stigmatized people. They talked down to folks that didn't engage the community, and they had really riots over vaccinations for smallpox back then. And then the last outbreak in this country, which happened in New York City, was organized. In fact, they ran out of vaccine one day and people were all nicely lined up to get their shots. They orderly went home. And when the vaccine came back in, they came back out in an orderly manner. They lined up. The health department worked with the community. The president showed up and gave the rah-rah speech. And we controlled smallpox, the last outbreak in this country. And of course, as you know, that's the one disease that we've actually extinguished in people from the face of the earth, even though the virus still is frozen in 2 or 3, maybe more, refrigerators and freezers around the world. I point out that public health operates in an incongruent environment, and we're living that today. Something really bad happens. Eventually, the resource allocators fund it, often not enough for too short a period of time, and quite frankly, often later than they need to. I think the real challenge we have is that the performance expectations far exceed both the event and the funding. We're seeing that right now. We're not out of this yet, and we're having to get Congress to finish the job continues to be a real challenge for us, despite evidence that this thing is not over yet. We know that just to give you a sense of our funding, not that at our peak we were adequately funded, but clearly much better today, but this gives you a sense that we've had precipitous reductions in funding. And even though the budget of the CDC itself has grown over time, a lot of that's one-time money, a lot of that's playing with the money, that's moving the money around. The wonderful prevention fund we had from the Affordable Care Act, as you know, a lot of the funding from that was first initially siphoned off for medical care activities. Not those weren't important, but that's not what the fund was for. And then the second thing they've done is they supplanted a lot of the existing funding in CDC out of the prevention fund. And that is a real challenge. And we've been beginning to lose people. Now, the fact we've lost over 10,000 workers is not just bad enough, but not only do we have to replace those, but the estimates are somewhere between 80 to 100,000 people just to get us at a functional level in public health. So if people are looking for a place to create jobs, I got an option for them. We know that the basic work hasn't changed. This is an updated thing of the 10 essential services. And, basically the work is anytime a new health threat, whatever that threat may be, chronic, infectious, environmental, whatever, enters the community, we have to identify it. We have to craft a response plan for it. And then we have to make sure it gets done. And that's a cyclic process. Hasn't changed over the years. And I'm a strong proponent of us building the 10 essential services so that every community has the capacity to address these things in an organized, functional manner. And while the health department doesn't have to do it all, for sure, we do a lot of things through partnerships and engagement of others. They still, in many ways, need to lead this process at some level. So let's find out what we learned. So obviously, last December 2019, we had this notice of an outbreak in China. I remember getting a call from the editor for the Nation's Health newspaper, plus APHA's newspaper, saying, because she does this all the time. She sees an outbreak somewhere, she's following the news, she'll call me to ask me what I think. And, I thought this was a concerning one just because of the size, the fact that no one really knew much about it outside of the scientists that were tracking it. And then, of course, as many of you may know, right after the first of the year, it became pretty clear that we had a problem. It's basically a global pandemic. There's no question that this was a big issue for us. We're almost at the 1 million death mark for our nation. I remember the first 100,000 deaths and talking to reporters about that first 100,000 deaths and saying, boy, we need to get our act together before we get to be 200,000. And I remember them calling me up at the 500,000 death mark. And I'm saying, boy, we need to roll up our sleeves and do more here because we don't want this to get to 600,000. Now we're going to get to 1 million. Okay. Now, let's put this in perspective. The 1918-1919 pandemic, globally, 50 million people died. Okay. But they didn't have vaccines. They didn't know about viruses. They understood kind of about non-pharmacological interventions. But they did not have the tools that we had back then. We've got tools, and the tragedy we have is many of these deaths were preventable. And from my perspective, there's a lot of overall systems failures. Quite frankly, big one is failure of leadership and accountability in many places. I don't want to politicize that, but let's politicize that. Okay, there were people that decided that this wasn't serious, that they didn't need to engage on this. I was around for 9/11 and the anthrax letters. That is just not how we behaved. We almost got all naked going through, the airlines, and we didn't like it. We grumbled a bit. We complained when they searched, 90-year-old ladies in wheelchairs. We complained about that appropriately, but as in general, we were compliant, and we're still pretty compliant. because we understood the concerns after 9/11. And, we lost almost 3,000 people that day. We've lost almost 1 million people. And we're not behaving, in my mind, in an appropriate way for that. This was not a technological failure. The CDC lab test issue was a blip on the radar screen here. There are a lot more issues than that. This was not a scientific technological failure. In fact, science has been dramatic, and our understanding of science has grown exponentially. Our understanding of a whole range of things that we thought we knew, including wearing masks, grew exponentially. So I'm going to talk a little bit about the system, where we need to go based on some 5 examples in these categories, just to give us a sense on where I think we need to go. So, we knew that our disease surveillance system capacity was very limited. Although other nations that had really great systems, Britain, for example, their cataloging of variants and their tracking of variants was at a very high level. Ours was rudimentary. Not that we did not ask for this. Tom Frieden asked for money to modernize this system when he was a CDC director very early in his tenure at the CDC director. I remember he was there almost 8 years. Yeah. So 8 years plus 4 years of Trump, a little bit of money came in, still limited capacity. That's a challenge for us. So his idea of advanced molecular detection system was right on the mark. I actually remember getting a call from him asking me to help advocate for this, and we did. But it wasn't something, they got money, but they didn't get enough money to really build that system. Even our modeling at the governmental level was pretty rudimentary. The good news is we could rely on folks like the folks at University of Washington and folks at Yale and the folks at Hopkins who were doing really ongoing monitoring. There are other systems out there, but those folks were really on top of modeling, not only just in the United States, but worldwide. And of course, our government did utilize that early on. Kudos to those folks. The Trump administration was listening to folks early on about modeling and using some of this. Deborah Birx and her folks, Tony Fauci and his folks, were using that information very early on to try to think through what they needed to do. And kudos for them to doing that. But it wasn't resident within our other systems. And we needed to have the best one on the planet. And we didn't at the time. Again, they're trying to do that going forward. Our disease surveillance and lab capacity. We had a great system to pick up influenza and track influenza around the country. And we tried to do some other disease surveillance systems, but understand they don't link to one another. They're not interoperable in any kind of meaningful way. Our lab capacity, we have amazing people in our public health labs. Some of them are linked to private sector labs. The challenge is the money for equipment. They didn't necessarily have the same equipment. In fact, we're losing laboratorians because, you can double, triple your salary going to the private sector. In fact, you can get the same salary going to the private sector too, but just get better equipment. And that's a challenge, just from a workforce perspective. But we need to make that. And we knew our supply lines, at least for this, was a challenge too. This was not a surprise. People have been complaining about that for years. One of the big holes in our system, public health is a data intense practice without adequate data systems. The systems are old and archaic. For those of you who are a little younger than I am, that's a fax machine, okay, if you've never seen one before. Dinosaurs, carbon paper, fax machines. And that's how we were sending information around. Someone took on pen and ink, filled out a form, put it in a fax machine, and sent that data to someone else. And quite often, they left off some of the boxes: race and ethnicity, age. And once you're 2 or 3 generations removed from where that data was generating, getting that and reconstructing that data is very, very difficult and often impossible. And particularly for, as you know, for small number statistics, to make any kind of inference on small numbers of things is very, very difficult. So we relied on the usual method. It's 8:30 in the evening, and I get a call from a couple of health officers, one who was a health officer in Milwaukee, saying, have you seen the fact, or have you heard the fact that we have lots of African-American men dying disproportionately from COVID. That's what happened. I got a call, I called CDC. Others had been seeing that phenomenon, but that's how the awareness was raised. That's not the way to do business. And we've got to fix this. We don't have a single patient identifier, for example. Everybody knows we need one, but we don't have one. And my challenge here is that every time we try to do this, and I'm a strong privacy advocate, no one should hear anything other than the fact I'm a strong privacy advocate, but they yell HIPAA. Nobody yells HIPAA when Amazon has your data or Uber has your data, and they know more about you than you do in some cases. And they often know more about you than their health system. Now they're getting to the health system, they may fix it at some point. My problem is the fact that, and we've actually designed the system to share data for critical business partners. We just, for one reason, there are all kinds of proprietary reasons which don't make, well, they make sense from a financial perspective, but not make sense from a health perspective, where people don't share data. And we have to fix that. We need to do that right now. Bob Redfield coined this term, the fact that public health are data archaeologists, and he's absolutely right about that. We're always doing things in the rear. So misinformation is not new. This goes back to the 1930s. Issues around wearing masks are not new. Mask mandates were controversy back in 1918, 1919 as well, although less so in many communities. I love this cartoon because I was really trying to find the source of this cartoon. I've been trying to find the source of this cartoon for years. And then one afternoon I was throwing through the archives at APHA, and it turns out this is APHA's cartoon from a 1930 cartoon book. And it's an important cartoon. It's actually, there's a French version of this cartoon as well. But it points out the fact that people have been sharing misinformation and disinformation for years. So it's just that the fact that we're in an environment which people can share at the speed of milliseconds has changed things dramatically. We know that communicating evolving knowledge is quite complex, right? The reason we didn't say wear a mask initially is because respiratory diseases, as a matter of course, generally do not get spread from person to person substantively until you get symptomatic. That's exactly how it was with SARS-1. That's absolutely not the case with SARS-2. But once we understood that, we recognized that we needed to wear masks. And this is, there are many communities that have done this, but this is one where the governor made mask wearing mandates permissive. And so those communities that required it in the state, you see this drop in cases, and in those counties in the state that didn't, they maintained high levels of disease. We know the social determinants drove the bad outcomes and inequities in this case. Exposure, those of us who go home and work from home, not so much exposure. Those of us who had chronic diseases, if they were exposed, were much more likely to get bad diseases. By the way, this evidence came out within the first 6 to 8 weeks in China. This was not new. China was seeing the same thing in terms of chronic diseases having a higher morbidity and mortality. And then in social conditions, in those places where they could take people and put them up in their homes and provide the wraparound social supports. By the way, we talked about this maybe 20 years ago, maybe a little more than that, when we were trying to deal with worrying about smallpox after 9/11. We talked about building social support systems, and places to put people, and designating hospitals would be the quote unquote smallpox hospitals and all of that in case we got a pandemic of significance. And some money went out the door to create a few of these centers. It was embellished doing Ebola a little bit, but not enough was done. And these social conditions continue to be an issue, right? With housing homeless people in hotels because there was no place else to put them, and they had no clients in the hotels. And then of course, structural racism in many ways, of course, is the root cause of a lot of these terrible social conditions. We've got to figure out how we address this in a meaningful way. We know it has clinical implications. This is an older chart from CDC pointing out the fact that Native Americans, African Americans, and Hispanics, and in some targeted communities, even Asians, were disproportionately impacted depending on where they are, both with prevalence of disease as well as hospitalizations as well as deaths. And, I like to be pretty simple about this whole issue of what you're doing and whether or not it works or not. When I was a health officer in DC, we used to get really excited when the infant mortality rate would fall by, 0.2 of a point. We'd get excited and do the Walter Mitty dance and slap ourselves on the back and say what a wonderful thing we did that year. As a nation, we lost a year overall across all populations of life expectancy, and over 4 years for African American men, over 3 years for Hispanic males, and women as well. And as you know, you don't get that back. If the world becomes right tomorrow and everything goes back and we fix all the social conditions in the world and everybody has universal access to quality, affordable healthcare, it will still take years to resolve these disparities. You don't get these back that quickly. So give everyone credit for Operation Warp Speed. It was both a business and a technological success. The technological success was built on 20 years of working on mRNA vaccines and the fact that we knew that these vaccines could be effective. There were a lot of hypotheses. As you know, people were thinking about how to use it for trying to wipe out the common cold, i.e. the coronaviruses and rhinoviruses that you get from that cause the seasonal colds. They were looking at it as a new model for influenza. They had certainly looked at it for Ebola and HIV. So the vaccinologists, when they saw that this was a new coronavirus, they jumped on this right away. And everybody knows the technological story. Let me tell you the business case here. So after the anthrax letters and an emphasis on biopreparedness, the question was, how do you get the vaccine companies, which, as you know, they've been dwindling in number over the years. And despite all the misinformation about the money that vaccine companies make, now granted, they're going to make a lot of money on this, but in general, vaccines don't make you a lot of money. Return on investment, because of the expensive investment up front, does not return that investment to make it worthwhile doing vaccines. So the government, which of course already is heavily endowed through our tax dollars in investing in vaccines, decided we're going to front load the research. We're going to front load a market, we're going to backload a market on the end to pay for these vaccines. And in doing that, there are hundreds of vaccine models out there, platforms that people are working on. The mRNAs worked real well. Some of the traditional ones have worked. The J&J vaccine is a little different platform. So there were lots of models out there. And the good news is they were able to do good science in a rapid period of time, recognizing they knew where their paycheck was going to come from next. And so they were willing to do this because a lot of these companies had to retrofit labs for production. They had to redo some of the research protocols. And of course, very early on, we made sure that they were pushed to get equity and an equitable representation of people in this, in these research studies, which turns out they were actually relatively successful in doing. But for those of us who are on the ground doing that last mile, getting shots in arm, a marvelous technological product like these vaccines are of no good, no usefulness if you can't get those shots in the arm. If people aren't willing to take them, if it turns out you need ultra cold storage to store the vaccines, if you haven't distributed those storage units, if you haven't made enough of them, so there are enough of them around, it doesn't work. And the challenge we have is that not a lot of attention was paid for this. Sometime around mid-August, we started getting notifications out to the states that they had to start putting their plans in place. This was not just like H1N1. This was not like having drive-throughs where you can stick your arm out the window and stick a vaccine in, in someone's arm, because it's a brand new vaccine. We ultimately did do drive-throughs and stuff, but the challenge we had was creating systems so that the vaccine didn't denature between the time it came from the refrigerator to the time it went to the syringe to the time it went into the arm. We decided to do it in large volumes. So we disenfranchised anyone in the inner city community right up off the bat, small providers who had the patients right up the bat. So there were real challenges in this as we went through this early on as part of this process. But we know that it's highly effective. It wasn't sterilizing vaccination like we thought. In other words, there's a lot of people, they didn't do the studies early on either. They did some look backs, and we knew that it prevented early illness and death, which is what the studies were designed to do. I wish we had done studies on whether or not it would prevent infection, but the problem was they had to decide as part of that rapid study process what they were going to focus on, and they focused on severe illness and death. We always know that hand washing works. We were concerned because of fomite transmission, lots of studies that said the virus lives on all kinds of surfaces. We spent a lot of money, swabbing surfaces and testing surfaces. And it turns out it's probably not the predominant way. In fact, it's really a minor way that people get this disease. Unless somebody actively infectious coughs in their hand, touches a doorknob, and I dutifully come on behind them and then touch my eyes, nose, and mouth, I'm very unlikely to get infected. There is aerosolization though. It does hang around the air, particularly in healthcare settings with very complicated and compromised people. So we do have to be concerned about that, but theoretically masks will help, and hand washing certainly is a component of that. We know that our basic public health containment strategies work. Testing, identifying cases, contact tracing, quarantine isolation, that cycle of classic public health does work. It doesn't work when you have such large volumes of people that you really can't do meaningful contact tracing. And so we had to come up with new mechanisms to do that. And so proximity apps and a range of other things. And now wastewater surveillance as a new tool to identify when we have peaks and valleys. We know that the virus is excreted in the stool. It's not active virus, but we can test for it. And it turns out that it's a great community environmental surveillance tool that one can use. We know that social distancing work. This is a chart from the 1918 influenza. Different communities had different experiences, but you can see that St. Louis had a good experience. They locked down early, they wore masks, they kept people from one another, and they had a really good experience compared to other parts of the country that did not. And of course, we utilized that practice for the first time as a globe, as everyone on the planet, locking things down. We threw our economy in turmoil. By the way, this was not a surprise to anybody who's been studying this stuff for a while. The folks that conceived this concept of flattening the curve absolutely understood we would throw our economy in turmoil. But again, the strategic messaging didn't go on to that. The briefing of policymakers was not necessarily a part of that discussion. A discussion about how long you do it and when can you relax them and how do you relax things. It's easy to shut down. It's really tough to reopen. And we've now seen it, the fact that we're now very resistant to locking down. And those parts of the communities are now getting hit again. We're now seeing the stress that those health systems are under now. And our therapeutic interventions got much better over time. Initially we had nothing, just like in 1918, 1919, we had nothing. General supportive care. We'll feed you, we'll water you, we'll watch you, we'll try to keep your temperature down. That's what we could do for people. If you got in respiratory distress, we intubated you. Turned out that was not a good thing to do. So we learned all kinds of new ways to manage the airway and manage oxygenation. Things that weren't a secret. The anesthesiologists have known, and critical care folks have known that for years, but expanded to everybody and not simply reflexively doing what we were doing. Interestingly enough, the Chinese knew this, offered to help us with this. And we said, we can handle this. We got this. We're America. Yeah, we did learn it over time. We did learn pulmonary management. And we also understood that this was an inflammatory disease. And so many years of science going into understanding how to do immune modulation around cancer and autoimmune diseases. We were very quick to go to steroids and antibody-rich plasma, monoclonal antibodies. I mean, we understood this science pretty clearly, and we were very clearly able to take that technology and that understanding and put it into practice. And that comes from enormous investments in research. This is a doubling of the NIH budget practically at work, because we've learned this stuff real well. The fact that, it's not really good to give a person one antiviral. We learned that from HIV. People tend to do better with antiviral cocktails. So we've learned a lot about how to manage this. And, the survival rate is getting much better because of that. And then the violence against healthcare workers. This is a strange phenomenon. I remember clapping and standing in my living room, actually, because we were still staying at home, when healthcare workers were being applauded by, everybody in the community. Folks remember that? Yeah. Public health people, not so much. Again, we're invisible, nobody sees us. But nonetheless, we're happy for them, and they were getting applauded. At the same time, the public health workers were getting whacked. You guys are making us wear masks. You're doing this. We're doing that. Now, all healthcare workers are really become viewed as tyrants, and we've got to fix this. I'm real clear on what the solution to this is. First thing we need to do is reestablish the rule of law. I never had a problem worrying about going into a community as a health official. I went in a lot of tough communities. I went into communities knowing I was going into an angry community over something, some funding we cut, something we hadn't done right. I knew that. I knew there were people in that room with guns, but I never felt afraid. And no matter what happened, I always thought my boss had my back. My boss might yell at me. My boss might say I did something stupid, but I always thought that they had my back. Not so much anymore. And we've got to do something about that as well. We've got to emphasize the skill sets we know most, and that's going to be important for us to do. Whole new set of skills. Most folks know these skills are there. A lot of people do them, but we don't do them with intention. We've got to do that, and we've got to do that for everywhere from the top person down to upper middle management. We've got to have all these skills, including the political skills that are necessary to operate in a highly charged political environment. Public health is about policy change, and therefore it's important that we understand that. We don't want to change, we don't want to be politicians per se, but we need to have the political skill set to manage in a political environment. So if we talk about the future of public health, the central challenge for our nation is how to build the next generation public health system. It's got to be a system that's robust and sustainable, where somebody feels that they're the chief health strategist. I would argue that's your governmental public health entity. Some communities, it may be the Boys and Girls Club, it may be the hospital, et cetera, has taken that role on, realizing someone else has a legal authority, but someone has to be in charge in those communities. And we've got to make sure that all the systems are in place to provide the services that people need as part of that process going forward. We need to realize that that system has got to do the 10 essential services. That system has got to be one that is charged and focused on actually dealing with the systems problems that are in that community each and every day. If we don't build that system to do that, we will continue to pay a lot of money on the healthcare side of the equation. It's got to be an integrated system that can address any health. And so all these things, not just infectious diseases, but anything that hits us is important. So one quick case study, think about having asthma, common clinical condition. There's a disparity in that. We see a lot of asthma. We know when asthma is going to occur because of seasonal asthma, seasons, et cetera. But we don't treat it like we treat measles outbreaks. So imagine we have a system where there's 10 cases, but they go to 4 different hospitals, small numbers, so nobody would pick it up. All these kids are out on the same day, sick enough they had to go to the emergency department to be treated. Their home inhalers didn't work, so they were pretty ill. But they got picked up. They got picked up because the school system was linked to the hospital, was linked to the health department in a confidential manner, maintaining patient confidentiality. They saw a blip and they were able to go in and do what we always do. They do an epidemiological assessment of what went wrong. They look at the kids, they go in their homes, they go to the daycare, they talk to people. And as I said, no single entity would have picked this up had we not had a system to track these kinds of things. Remember, this is a chronic disease utilizing infectious disease methodologies to address this problem. And if you do this in a way that also addresses the social determinants of health, what you find is that all these kids rode the same school bus. School bus had a broken tailpipe. Broken tailpipe, noxious fumes. Noxious fumes trigger asthma attacks. Okay? Kids don't get sick until they go to school or when they go home. Nonetheless, that's why these kids got sick. And who's the hero of the day? I would love as a public health person to take credit for that. It's the bus mechanic. The bus mechanic goes in and fixes the tailpipe, then inspects all the other tailpipes, fix the other broken tailpipes, and then of course checks the brakes and this and that and the other. So that at the end of the day, you have a much more functional system. You're safer, you spend less money. The transportation system is better. Kids are in school because we know that school absenteeism is the social determinant in itself. And quite frankly, this is the way the system should work. If we have a good functional public health system, engaging across sectors, taking data from a bunch of places in an appropriate way to make data-driven decisions and get a much more healthy community. And someone argued that the Wall Street Journal is relatively conservative newspaper, but even the Wall Street Journal understands the importance of funding public health and recognizing that we've spent trillions of dollars on something that probably had we had a more effective public health system, we would still have the pandemic, but maybe not 1 million lives lost. I end with this proverb because I think it's important, which says, until the story of the hunt is told by the lion, that's us, the tale of the hunt will always be glorified the hunter. Public health is a story to tell, and we really need to spend a lot more time telling our story. With that, I'll stop. I'll thank you, and I'm happy to take a few questions. Thank you. Yes, ma'am.
It touched my heart that I am teaching the right things to my students. I have seen a very compelling graph out of Hong Kong for how this new variant is impacting people 65 and over who are not vaccinated, and the number of deaths of people 65 and over who are not vaccinated. I was also one of those people who said, first 100,000 people, this country's gonna lose its mind. When we get to 250,000, it's gonna blow up. We're over 1 million now. But this is like a hot knife through butter. And there are a couple of areas in this country that are rural, elderly, and unvaccinated. Is it a thought in anyone's mind besides mine that when this gets to those areas, it'll be like a hot knife through butter?
The question was, the challenge is that we thought that would happen. And understand that a nation this big everyone doesn't get hit at the same time. And so the big urban settings got hit because of the population density. And New York, Chicago, LA, people on the coast primarily got hit first. And then as it moved into the center of the nation, the problem was that they had people in those communities who were saying, for a range of motives, which we now know were very political, that these were, blue state governor problems. These were urban settings. In some places they tried to racialize it, or say these were, Blacks, Hispanics. Certainly went after Asians because it was, we believe it originated in China originally. And then, and the news that they listen to, since we've all now figured out we only want to listen to stuff from people who think like us, talk like us, and is that all they're hearing is negative stuff about the outbreak. And even when they see people dying, they're believing it. I mean, we now know we have lots of testimonies of physicians who got people on their last breath. They're gasping for air. They're intubated. And now they want to be either vaccinated because they believe the virus is real now, or they're dying of something else in their minds. They're being told, you got COVID? Nah, I don't have COVID, but that will eventually happen. But I'm not real optimistic. Now, I do think there's one way we can help change the tide of that. One thing we can begin to do is do more listening and understand what the issue here is. This is not necessarily about wearing a mask. This is about being told to wear the mask. And I think we've got to get better at risk communication and recognize that there's a spectrum of folks. People hear things differently, they respond to different things. We've got to figure out how to segment that market and from a communications perspective to reach people using words and languages that they care about and using trusted messengers that they care about. So as you know, here at George Mason, your climate center, defined the climate communication issue with the 6, communities, and figured out how to target those communities in terms of appropriate messaging, with the idea of recognizing you got these folks on both ends that either don't spend a lot of time here because they're not going to get there anytime soon, and these folks you don't need to spend any time because they got the message, but trying to get to that influenceable middle. And there is an influenceable middle out there, and we really need to spend a lot better time figuring out how to communicate with them. Now, Frank Lutz, who's a Republican pollster, has done some work with that with the Beaumont Foundation. It's really good work. So if you go to the Beaumont Foundation website, they're in Bethesda, and they have done some really, really great work on messaging, on how to talk to communities that are tend to be more conservative, certainly tend to be more Trump supporters. They align very much with President Trump's thinking and community, and how to talk with them about this issue. And when and he's had some focus groups where at the end of the focus group, people who were violently against anything about the vaccine or the mask, et cetera, have been either fully converted or at least moving in that direction. So the answer is possible. Take a lot of work. Sir.
So I'll put my question down. So GMU is currently working with plans and initiatives to rapid diversity. But if we look at the school, the student body is 85% female, faculty is 75% female, and a quick scan of the APHU website suggests that the board is 66% female. So I'm wondering, given conversations about DEI, how might the disparity in professionals impact health outcomes? And what might schools such as CHHS do to improve the gender disparity?
Yeah, public health is overwhelmingly has more women in the field than men. There are some other disparities though. There most of the folks that run things in public health are men, not women. Your dean being one of the exceptions here. So we've got a lot of work to do, both in racial and ethnic, especially in gender diversity, and I just think we've got to do that with some deliberation. I mean, the intent of getting more men. We actually went through that discussion on our board when we set up a nominations committee and looked and said, well, most of the men are rotating off the board this year. Why don't we want to try to put a few more men in here? Mostly because I don't vote. I'm on the board, but I don't vote. So we wanted to have some voting members. And so we were successful in moving that back in that direction to get more in line with the field. So we are in line with the field, but not necessarily equally diverse. And yeah, men are 50-50 in our society, but not necessarily 50-50 in the field. And I think we got a lot of work to do. But I do think the way you do that is through thinking about it. So I have no questions about the fact that I'm an affirmative action student. I went through an affirmative action program at the University of Illinois. where in those cases, I don't feel that I got a free ride by any means, because I had to compete like anybody else in the school, but they were on a hunt to find people they thought would be good medical students. And medicine wasn't anywhere on my radar screen. I had no interest in being a doc. You know, why would anybody want to be a physician? I wanted to be a researcher and be a gene splicer and do molecular genetic research. Ultimately, I went to medical school to get a good basic science background to do molecular genetic research. Found out, hey, I'm a terrible researcher. I just don't have patience for it. I'm an internist with a surgeon's mentality, which is why I'm an ER doc. I'm an emergency physician, if you don't know, and an internist. But I fell in love with clinical medicine. Just fell in love with it, and then fell in love with emergency medicine while I was in medical school. So and then got dragged into public health along the way for a variety of reasons. I think we've got to identify early on people. Now we have an opportunity because we've got undergraduate programs, and we're growing. Public health is a popular discipline now. It's growing like a weed, and we're just going to have to incentivize more men to go into the actual practice. We need to incentivize more to go into governmental public health. The schools are cranking out MPHs. They're not going into the governmental public health system. Salary's a problem, for sure. And now the fact that they feel they may be threatened if they work in the government is another barrier. But I think we can fix that one. That help you? Yes, ma'am. And then this gentleman up here.
Hi, Dr. Benjamin, Erin Mon, and I only bring this up that I'm the chair-elect for the school health section because I loved your school health example. And it actually leads to my question. My question is, like, that's such a great innovative solution and using technology, I'm sure brilliant brains and things. Are there other either just examples or things that facilitate those types of things? Because I feel like that's where we need to go if we're really going to change public health, not change public health, but change the appearance of public health and really be able to do and make the changes and impact we know we can. And I just wondered, from all the experiences and examples that you've noticed, what are some of those things that really facilitate being able to make innovative changes like that?
Yeah, well, the way we've been able to, I think, in public health, make meaningful changes. First of all, you get a bunch of people together in a multi-sectorial way to solve a problem. So Robert Johnson Foundation has a cultural health prize they give. They have these, they bring together small amounts of money, groups, to incentivize them to put together multi-sectorial teams to solve a problem. And what they've experienced has been that using those multi-sectorial teams, leveraging each other's experience, knowledge base, tools, they've been able to solve, let's say, a problem with bringing down better control blood pressure, diabetes in a community. But the real thing that happens when you bring those groups together, and if you can keep them together, is they start solving other problems. They sometimes find out, boy, this model works for unemployment. We just lost a plant. The plant closed. How can we solve that plant? Let's bring this same group of people together to think about how we can bring more jobs in this community. So it turns out that once you get people working across disciplines in a multi-sectorial way, they begin to solve other problems. And the way they agree on it is to say, well, there's a health impact on that. So they look at health in all policies, and they put health as a metric, and it tends to drive improvement and change. Right now, we're doing that with the Beaumont Foundation on racism. We've gone out and looked at all the various policies that are evidence-based, and we've put them on a matrix. And now we're going out to try and find communities that are willing and ready. Some of those that have said racism is a public health problem. Here's a list of policies that you folks can do that can help begin to move your community in a more tolerant way, and one that addresses racism and discrimination at the same time, and hopefully promote racial healing. So
I was curious, and this is a bit troubling to me, given our polarization in society right now, and you highlighted that politics is obviously important because it determines what can be done and what can't be done, and the misinformation cliff that you pointed out. What is the role of public health or public health professionals or the APHA? Traditionally, us professionals are not very assertive when it comes to the political realm, where, yes, we'll correct misinformation when we can, but we're not going to come out and say, the president is an idiot. This is what he's telling you is a lie and it's going to kill you, and you should not listen to it. Or we're not lobbying the way ExxonMobil is lobbying. I don't know if we have the money to lobby even, but what do you think the range of options are? And should we be more aggressive, if you will?
Well, first of all, we do lobby. I have two lobbies. We have we're a 501c3, but we have an H exception, which allows us to do some technical lobbying. When we don't lobby, we educate. It's not lobbying if a member of Congress calls you and says, give me advice on X, that's not lobbying. If you can get someone to ask you that question, that's not lobbying either. You just can't do it directly. So we often get asked our opinion on stuff. That's the first thing. Secondly, I think that we need to start speaking truth to power. Fire me. It's okay. I will double my salary. I have no problem with either one of those problems, okay? That doesn't mean it's right. You do have to pick your battles. As a health director, I've often had to pick my battles and decide when it was right to say something and not wrong, but I've never changed my values. Sometimes timing is everything, and in terms of engagement. But I think we need to continue to treat truth to power. And I think we have to, when we have colleagues, we do some self-policing, because there's a couple of health officers out there who should be fired right now. One of them's in Florida. And I don't have any problem saying that, when I went to medical school, there were a lot of people who are really smart in medicine. I wouldn't let them touch me as a patient, okay? And there's some public health officials that just don't need to be in those jobs. And we need to speak out when they do that. And and when governors have said things that were stupid, I've said that too. Now the media's cleaned it up a little bit, but I've tried to call them on them. And when I've said something stupid, which I have, I've tried to correct myself.
No. I was just going to end the questions, because we have an opportunity at lunch if you have a burning question, to ask Dr. Benjamin about. So please join me in thanking Dr. Benjamin for a very thought-provoking reality check.
All right.
So very much.
Thanks, everybody.